Good afternoon, everybody. Welcome again to this live feed, and I certainly look forward to giving you some information that might be of help to you. Today is a very interesting topic because I've had numerous requests via Facebook and also by email that I talk a little bit about how I'm able to treat patients at a distance here in Las Vegas. And I thought that today I would devote some time and explain the system we use, how we go about it, and why it works so well. Obviously, I see, or shall I say, my patient population comprises about 70% of people that are from out of state and country. In fact, I see so many people from out of country that I probably see more people myself than the rest of Las Vegas combined see patients from out of country. I'm very proud of that. I also have dedicated my career to dealing with tough cases, patients that are spinning their wheels. And that is why almost 80% of my patients that I do IVF on have failed 3 or more times before I see them. I've had patients who've been through IVF more than 20 times that have come to me, and in some cases have been successful. So this is what I've dedicated the rest of this third act of the play called life to try to help those people that feel they're spinning their wheels and are not getting real answers and real assistance in other locations. Okay, now I'd like to also say that if any of you are interested in talking to me, having a consultation with me via Skype, if you're from out of state or out of town, or in person if you're local in Las Vegas, all you need to do is get hold of my concierge lady, Julie Dahan, who I call Mother Teresa because she's so sweet, but I've had to elevate her even beyond that to Saint Teresa, since Mother Teresa was canonized, as most of you know. Anyhow, jokes aside, Julie is wonderful. She'll be happy to set you up with a consultation with me. All you need to do is contact her via email by going to Julie, J-U-L-I-D, Julie D, at Sher IVF, S-H-E-R IVF.com. Email her directly and she will set you up for that Skype consultation. Alternatively, you can call her directly at 702-533-2691. Again, 702-533-2691. If you'd like to go directly to my website, sherivf.com, www.sherivf.com, you'll find a little form that you can fill in that allows you to apply for a consultation through Julie online. And once you've done that, she will immediately get back to you and arrange it for you. So while you're on that website, sherivf.com, you'll see a banner at the top of the page, and one of the little icons there says Dr. Sher's blog. Click on that, it'll take you to my blog, and when you get there, you'll find hundreds of articles that I've written. All you need to do is type in any title of interest into the search bar that you'll find on that home page. Click on it, and it'll take you to the article directly for your information. You can download it or read it or do whatever you choose. Okay, let's get down to talking a little bit about this practice that I'm in and how I'm able to see people at a distance and how we facilitate that, because I am of the belief that IVF is an emotional, physical, and financial burden. I really want to emphasize the fact that in order for us to be able to provide the best quality of service, we have to be able to provide not only the highest level of medical scientific treatment, but we have to do it in an environment that is affable, where I am available, and which is affordable. It is an expensive procedure, no doubt, but you should always look at the cost of IVF, especially those of you that know this to be a fact, because you've been through it so many times spinning your wheels, that the cost really resides not in the cost of a procedure, but in the cost of having a baby. And as I said, there's an emotional, financial, and physical cost. The physical cost can be minimized through good quality medical care. The financial cost is one that is hard to ignore but we do our best to provide packages and plans that make it more affordable for our patients. We're constantly focused on how to make IVF more affordable. And then the affability has to do with the interaction between me and my patients. I take this extremely seriously. It's important to me that I be there for my patients, and that is why I give every one of my patients my personal cell phone number so that they can call me at any time. I just got back from a vacation in Europe when I was floating down the Danube with my wife for some time, and during that 2-week period I probably got about 40, 50 phone calls, and everyone was answered from there, because I feel it's so important to be there for my patients. And I tell my patients that if you need me on medical issues, call my cell phone number, which I give them, and if I'm busy, just leave your name and phone number and I'll call you right back. And I do, on all occasions. So I ask my patients, because it's so important to know that the support system is in place, the emotional and the medical support system. And to me, it wouldn't be possible for me to have more than 70% of the patients I treat come from out of state and out of country, and do so with a growing practice who are not able to provide that kind of support in an environment of quality care. Now, no person can do this alone. I have a team of dedicated people. Top of my list is Julie. Julie is my concierge. She's not medical, but she knows about as much as any of my nurses do about the field, because she's been with me quite some time. Julie is available. I've given you her number. You can call. My patients can call her as many times as they like a day, and she will help them, and she will assist them. She's the glue. She's the go-between that makes sure that my patients are always happy. And I tell my patients, if you're unhappy and you don't let Julie know or me know, take responsibility for it, because we don't want that to happen, and we will rectify it if there's a problem at any time. Okay, so then how do we make this happen? Well, first and foremost, I start with a consultation with my patients. And as I said, for people from out of town and country, it starts with either Skype or a telephone consult. I prefer not to do telephone consultations because they're not personal enough. And when we see each other over the internet, we are able to sense where each one is coming from. I have a much better gauge by seeing you and hearing you, as you do of me. And it's so important that there be that link, that feeling of support, that feeling of unanimity that is so important to making an IVF experience both endurable and possibly even enjoyable. And from the letters I receive from my patients, from what they tell me on the phone, and from what they write on the internet, clearly we're being successful in this regard. Now, from the point of me having a consultation with a patient, which takes about an hour, and by the way, to do that consultation, Julie sends you a questionnaire, which is quite detailed. It is so important that that questionnaire be filled in completely, to the best of your ability. And if there are difficulties in filling it in, call Julie. She'll go over it with you and make sure that it's filled in correctly and fully. And then she'll ask you to send me as many of your old medical records as possible. We don't have to have all the records on the very first visit, but it makes it much more meaningful if the records are there. And Julie will triage you through it. If you can't get hold of your medical records, she'll help you get them. She'll do whatever she can to handhold you through the process. Unfortunately, some previous practices that you come from don't always provide all the necessary information. And we're on top of them to make sure that that's available for us whenever we can. Usually, the consultation is me going over your history with you, and then in a period of about 1 hour, I discuss my reasons for considering certain approaches to treatment. I'll present them to you, and in the spirit that it's not my job to tell my patients what to do. I think that's both arrogant and unacceptable. My job is to give patients information so they can make their own informed choices. And that's what I plan to do when I talk to you. The consultation is immediately followed up with a letter which goes to you that summarizes everything we spoke to and gets delivered to you by email. So usually within a half an hour of us having spoken, that email's going to be on your computer and summarizes everything we've said. In addition to the email, there'll be a list of articles that I want you to look up on my blog that are specifically designed to cover those issues that are central to your particular problem or problems. So it's very important that you go to those articles on my blog. And the way you get there, as I said earlier on, is you go to sherivf.com. Then when you see the banner with the little icon which says Dr. Sher's blog, you go there and then type in the titles that I give you into the search bar one at a time. Click, it'll take you to the articles for downloading or reading. And once you've done that, you can come back to me either on the phone, because I'll by then have given you my cell phone number, or you can email me or text me with additional questions, and I promise you I will respond promptly. So once you get the letter, the next step is that Julie will call you immediately. She will make contact with you and set you up for a consultation with my administrator, Sharon Jockman. Sharon's been with me for 18 years. She's very seasoned. She understands all the nuances of insurance coverage, who does and who doesn't cover, how much they cover, and if there's ever a question, she'll undertake to research it for you and provide you with the necessary information. Sharon will then send you, or will provide you, with the dates when I do my cycles. Now, I do all of my cycles in batches. There's somewhere between 6 and 10 batches in a year, and those are known a year and a half in advance. So when you speak to Sharon, she'll give you the exact date the cycle begins, and the exact date, therefore, that you'll need to be here, and when you leave. And she will tell you when that is and give you the choice of selecting the cycle that best suits you. I usually advise my patients to always apply for the closest cycle, because there's no penalty, there's no deposit, you're not under any obligation to me whatsoever or to us. So by giving Sharon your name for the earliest cycle, she can then put that down, and she will then be able to contact you as the cycle draws near to let you know that you're now coming up to the point where you have to either make a commitment or she will give it to someone else. And you're free to walk away or to defer. So if you give Sharon your name for the earliest possible cycle, when she calls you, you can always say to her, you know what, Sharon, it's not convenient for me. I'd like to do this in the next cycle or 2 cycles later, and all she'll do is defer it for you with no prejudice. But at least you're on her radar screen and you're in control, so you can decide whether to move it ahead. Conversely, if you were to say to Sharon, put my name down for a cycle several months later, and you then change your mind in the interim to come into the earlier cycle, it's very possible that you won't get in at all. So my suggestion is always give Sharon the earliest possible date that you can attend, and she will make sure that she contacts you as the time draws near to get a commitment or move you on or allow you to go if that's your choice. There's no pressure and there's no commitment at any time. Now, once Sharon has spoken to you and has sent you documentation and information by email for you to review, you'll also have her phone number, so you can call her back with any other questions that might crop up, and she will stay in touch with you. From that point onwards, Julie then takes over again and hands you over to the nurse manager, the clinical coordinator. The clinical coordinator will develop a color-coded electronic calendar for you, which lays out every single step of the tests we will have discussed in our consultation, or that I need to get done. She will have laid that out for you, and she will arrange for you to get those tests done. The electronic calendar that she builds up and emails you in advance of that consultation contains every single step along the way that you need to follow. And she'll stay on top of you to make sure you do it. And Julie will stay on top of you. And if you have difficulties in getting the tests done that we require, Julie will facilitate them for you. All you need to do is call her, and she'll set it up for you and help you get it arranged. So take advantage of these facilities, without which I would never be able to provide the service that I do at a distance where, even though you are far away, sometimes in Australia, Middle East, Japan, China, Europe, South America, Canada, wherever you come from, and my patients come from numerous countries from all over the world, we'll be able to give you the quality of care that you'd get if you were right in front of me. In other words, I need be no further than a telephone away from you. So take advantage of my need to be involved more than simply at the point of contact. I need to be involved in all aspects of your care. So once you've spoken to the clinical coordinator, they'll give you their contact information, phone numbers, emails, and what have you, so that you can reach out to them on any question at any time. And these consultations with a clinical coordinator and with Sharon are free of charge. So they will then keep you updated and set up scheduled consultations. But there may be unscheduled consultations as well, which you want to initiate, or the clinical coordinator will initiate should the need arise. When they're through with that, they will then hand you back to Julie, and Julie will set you up with a final wrap-up consultation with me. And that is also free. And during that consultation, we'll go over all aspects of your care. We'll look at all your results, and I'll dot the I's and cross the T's so that we have everything lined up, appropriately ready for you to go and cycle at the designated time. But once that's done, then you start preparing, with the help of our team, to get you ready for your cycle. And that may require, if you're local or nearby, for you to come in here for certain evaluations and tests. But if not, then Julie and our team will arrange for you to meet with your gynecologist, with your primary care doctor. You don't need to see a reproductive endocrinologist and get caught in the crossfire. What you need to do is have it done by your regular primary care OBGYN, and we will facilitate that those tests get done for you through your doctor's office. So don't be concerned about it. We do that all the time. We want to make this a seamless and very easy process and non-stressful for you. All these offers of contact don't only apply to you, the female patient, but because there are usually and almost always two people involved, a man and a woman, all the invites to be in contact with us apply equally to your partner. All right. Now, once all that's done and you're ready to arrive, then this is how it works. You start a birth control pill at home, and I usually use a monophasic pill such as Desigen or Orthonovum 135 or Low Overall or something like that, which you would start taking anywhere in the first 5 or 6 days of your cycle. But before you start taking the birth control pill, one thing has to have happened, and that is your blood will need to have been tested for your ovarian reserve, which is your AMH test done any time in the cycle, or FSH, LH, estradiol, and this will be done on the first, second, third, or fourth day of a bleed. If you're not having regular periods, we can induce a period with the hormone Provera, which is a progesterone derivative, and when your bleeding starts, then in the first, second, third, or fourth day of bleeding, you get the FSH, LH, and estradiol done. All the other tests that are needed can be done any time in the cycle, even while you're on the birth control pill. Some patients will require a immunologic screen, which can vary in its scope depending on the individual circumstances. When that's required, it can be done while on the birth control pill or before you go on it. And for those that require a sonohystogram or a saline ultrasound, that too can be done while you're on the birth control pill. In some cases, both the sonohystogram and the immune testing can be done when you arrive here for treatment. That applies in cases where the woman is not going to be having an embryo transfer done in the same cycle. So we don't have to worry about the uterus being evaluated through either hysteroscopy or a sonohystogram while you're asleep at the time of egg retrieval. And we would do that free of charge. Alternatively, if you need immune testing and you're not going to have a transfer done in that same cycle, then we can do that blood test for you when you get here. So you needn't worry about the difficulty of getting that test and the sonohystogram done at home. If you want to do it at home and you need the results in advance and would like to discuss those results before you make a decision, that too can be arranged, but much of this is at your own discretion. We will facilitate whichever way you choose to go. Now, you start the birth control pill in the cycle, in the month before the cycle of treatment. You need to be on the pill for at least 10 days. And as I said, the birth control pill can start anywhere up to the first 5 days or 6 days of the cycle. Now, the later you take it, the more the likelihood that you might have some irregular bleeding in between while you're on the pill, but that won't prejudice your cycle and won't be risky. Be inconvenient, and you won't like it necessarily, so the earlier we start the birth control pill, the better. Now, when you're on the pill, you will be overlapped with an agonist like Lupron, Buserelin, Supercure, Superfact. While you're on the birth control pill, it will be overlapped for 3 days. Then we stop the pill, and 5 days or 6 days later, you'll have a period. That period is the time at which you only have to do one thing at home. Have your blood drawn for the measurement of your blood estrogen or estradiol level, and an ultrasound to exclude the presence of ovarian cysts. Once those are done, you're ready to go, and you will then report to us, and we'll say to you, you know what, follow the calendar as we've sent to you and readdressed to you to review, and start taking your shots. Now you will then begin the stimulation. In some cases, you'll start straight off with varying doses of FSH, like Purigon, Follistim, or Gonal-f, while you either continue at a lower dose of the agonist, the Lupron, Lucrin, Superfact, Supercure, Buserelin, and continue on until your follicles are ready. And in other cases, when your period begins, again, depending on circumstances, the moment your period starts, you will switch from the agonist that I've just described to an antagonist, ganirelix, cetrotide, or orgalutron. We call this long protocol the agonist-antagonist conversion protocol. This will all be discussed at length when we talk and when you talk to the clinical coordinator. And then you'll continue on one of the other. In some cases, the FSH, Follistim, Gonal-f, or will be started right then on the spot and continued along with the agonist or the antagonist. And in other cases, if you are very severely affected by diminished ovarian reserve and you have an AMH of under 0.1 nanograms per milliliter or less than 3 picomoles per liter, we will use estrogen priming. And that requires that for the first week on the antagonist, on the ganirelix, on the orgalutron, or on the cetrotide, you will take estrogen injections twice a week or skin patches, preferably the former, and we'll tell you how to do that. After that 7 or 8 days is over, we will then continue the estrogen priming, and we will then give you the injections of the fertility drugs. The dosage and regimen will differ. We'll then, you will then arrive here with us 7 or 8 days after starting the shots with the FSH, the Follistim, Gonal-f, or Purigon. And you arrive here with us 7 or 8 days after that is started, and that will coincide with the first day on the calendar when our cycle batches begin, which is what Sharon will explain to you, and the clinical coordinator will orchestrate to make happen. And at this point, you'll arrive here and I will take over. in my practice, I'm the only one who treats my own patients. I'm the only one you refer to on medical issues other than the clinical coordinator. On non-medical issues, you talk to Julie. And I will then do all the ultrasound monitoring, all the testing. I will end up doing the egg retrieval. And in most cases, after doing the egg retrieval, we'll harvest the eggs, fertilize the eggs, and take them to the blastocyst stage where they'll be 5 or 6 days into fertilization and cultivation in the laboratory, culturing. Those that don't make it to the blastocyst stage would not have made a baby had they been transferred earlier before they reach the blastocyst stage. So there's really no point in transferring embryos that don't make it, because those that don't make it are almost invariably chromosomally and genetically abnormal, and you don't want them anyway. So I make a thing of advising my patients, unless they feel strongly against it, or they are older and they simply want to, excuse me, I'm going to sneeze, I think. But anyhow, they will be basically allowed to transfer as blastocysts and not as cleaved embryos. Embryos that don't make it to blastocyst aren't worthy of use anyway. So who are we kidding? So bottom line is, we prefer to go to blastocyst with some exceptions. Now, in some cases, we will be doing embryo biopsies at the blastocyst stage. A few cells will be removed for PGS, pre-implantation genetic screening testing. And that is something which you are probably aware, not until 2004, was very limited in its scope. In 2004, we were the first people in the world to introduce PGS screening of embryos that allows evaluation of all chromosomes at a clinical level. And we were the first to introduce this. By doing this, when it's indicated, and as I've said previously, not everybody needs it, and it's an unnecessary expense for those that don't need it, but for those that need it, it helps us determine by selection which embryos have got all 46 chromosomes. If we transfer those embryos selectively, we multiply the chance of success, we dramatically reduce the risk of miscarriage, and we minusculize, that's a new word, the chance of a chromosomally abnormal live birth, such as occurs with Down syndrome. So it's good for some people, especially older women, especially women who've had unexplained IVF failures, especially women with recurrent miscarriages, and also women that have a particular genetic problem that needs to be evaluated. So yes, this is called staggered IVF. In these cases, we take the eggs, and then the woman goes home straight after the eggs have been removed, meaning she only has to spend 7 days or 8 days with me in Las Vegas. And then she goes home and we stay in touch with her, letting her know how the embryos have developed after fertilization. And it also enables us to come back to them with the results of the genetic testing. For older women or women who have diminished ovarian reserve, we use embryo banking. Here it takes, the woman comes for a cycle, we biopsy the embryo, she goes home and rests the cycle, and then we repeat it a month or two later and keep stockpiling the blastocysts that we biopsied till there are enough of them to justify the cost of the genetic testing, and then the same thing applies. We select the best embryos, advise the patients which ones are the ones that can best make a baby, and then they return at a time of their choice for the embryos to be transferred under hormone replacement therapy, what we call a frozen embryo transfer, FET, which doesn't prejudice the embryos. If you freeze them properly and you only freeze well-expanded blastocysts, their chance of survival is 90 to 95% when you freeze-thaw them, and when you do thaw them, the chance of making a baby is at least as good as when the embryo was fresh, maybe even better. So embryo banking is there for those people that need to stockpile embryos to have a better chance, a longer chance at having access to those embryos for a baby or more babies down the line. Now, when this is all done, Again, let me reiterate, women that are coming for conventional IVF, where the embryo gets replaced fresh into the uterus, will spend 12 days, 10 to 12 days in Las Vegas, with their husbands only really needing to be here for 1 day, which is the day we do the egg retrieval to have access to the sperm. Of course, since what happens in Vegas stays in Vegas, we usually advise the husbands to accompany their partners here, or the men to accompany their partners here. But the truth is that we don't really need the man, because guys, we men are not as important as we think we are in this equation. The day of the egg retrieval is the day to be here, and in cases where the man's got normal sperm and we've got specimens of his sperm frozen and stored, he doesn't even have to be here at all. And then when it comes to the transfer of embryos, when the embryos have been, the blastocysts have been frozen with staggered IVF, the man obviously doesn't have to return with his wife for the frozen embryo transfer. So this is how we make IVF doable, not only bearable, but hopefully non-stressful for patients that come here. But it doesn't end at that point, because once you've made contact with our patients, we like to view our patients as family. Hopefully we remain in contact. Julie is the glue. We get the photographs of babies, and when you visit here, you come and see us, and hopefully when I'm in your neck of the woods, I'll pick up the phone and call you and say, hi, can I see the babies? Because I'm a proud grandfather, and I want to see all those babies that have been there. And believe me, there have been quite a few. I've been doing this for 34 years, and have been influential in the births of probably more than 18,000 babies in this time. So there hardly is a corner of the world where I don't have a footprint when it comes to babies. I'm not saying all of these were initiated through my personal hands-on effort. Some of them were initiated, or many of them were initiated, through the doctors that I've had the privilege to work with at Sher Institute over the years. All right, so that then is the picture. Obviously, once you've done the procedure, the woman goes home if she's from out of town, and 8 days after the embryos are transferred, we have her blood drawn and do a blood pregnancy test. And if the levels are, if there's clear evidence of an implanting pregnancy, we repeat it 2 days later. It should double, and if it doesn't, we'll repeat it 2 days later again, because we want to see a trend of doubling every 2 days in the early part of pregnancy. And then 2 weeks later, an ultrasound examination is done by your own doctor, or if you're local, by me, and I will basically look for a baby, or hopefully not more than one, but sometimes there'll be two, but never more than two, hopefully, because we don't put back more than 2 embryos unless under great duress to do so. So usually it's 1 or 2. And I do it, or your doctor does it, and we communicate. If you're local, when you get to the 10th or 12th week of pregnancy, you'll come back to me and I'll do an ultrasound, and by that time we'll usually be able to not only confirm the health and well-being of the baby ultrasonographically, but be able to also tell you if it's a boy or a girl if you want to know, because I'll be able to identify the gender at that point. From then on, you hand it over to your OBGYN. If it's a multiple pregnancy, or you've got a history of complicated pregnancies in the past, or you're older, then we advise the participation of a perinatologist, or someone who's subspecialized in maternal fetal medicine. Just as a matter of interest, I too have boards in maternal fetal medicine. There are not many of us around, and that was my previous life, was dealing with complicated pregnancies. So if there is a problem that comes up in the pregnancy and you want to call me for input and advice, I'm always available to give you that advice as well, and at no cost. So feel free to do that for those of you that come here. During the time that you are waiting for the pregnancy test, and beyond that time, you'll be on hormone replacement therapy as prescribed by us, which means continuation of the estrogen and administration of progesterone daily or through vaginal progesterone administration to keep the pregnancy under control and to make sure that the baby gets adequate hormonal support. It's very important that that be stuck to. Let me see. Some people will be on steroids such as prednisone or dexamethasone or prednisolone. For women that are on that treatment It cannot just be abruptly ended if the pregnancy test is negative, while all other hormones can be stopped suddenly. This requires to be tailed down slowly over a week or two. And for those women that are pregnant, I continue recommending the continued steroid therapy all the way to about the 8th week of pregnancy, and then tail it off between the 8th and the 10th week until it stops. Whether you're pregnant with a healthy pregnancy, it should then continue, it should then stop. Now, there will be other medications that my patients are on for medical reasons. Those will be individually dealt with through me or the clinical coordinator during consultations. But we don't shut the door when patients leave here. We're available and accessible to you for any issues that might arise in the first trimester. If you need advice or you need input, our team is always available. So that then is how we are able to provide care, hopefully good care, to our patients at a distance, and why proudly so many of our patients who do come here feel like they really got a good deal, in the sense that they were treated with dignity, respect, and affection, and treated with the highest level of medical care. I thank you all for your attention. I hope you don't view this as me trying to promote what I do, but rather to enlighten those of you interested in receiving care from me as to how this would go and how it would transpire. Have a wonderful day.